So here you are watching drug-induced sleep endoscopy with BIS monitoring in a 42-year-old male with history of mouth breathing, snoring, choking. You can already hear the sound, loud snoring. His body mass index is 21, so he's very, very fit. In fact, BMI is quite less, but his AHI is 50, 55. So most of which are obstructive. Both apnea and hypopneas are there. Apneas are more. You can see the deviated septum on the left side. Can you see this? Nasal valve is blocked. And a small spur on the right. As I go inside, you can see the turbinate hypertrophy on the left side because the lower spur is on the right side. Now, as I go inside, you see that there are no adenoids. The salpingopharyngeal folds are also grade 0 by Agrawal's classification. And there is a both AP as well as lateral collapse of the soft palate. At the base of 75, we do not see any significant collapse of the tongue base and the epiglottis. There is a incomplete collapse, but that's because his mouth is open. Now I'll close his mouth. I'm closing his mouth and we'll see what happens. Fine, I'm only closing his mouth. The moment I close his mouth, see what happens. The base tongue collapse is completely gone. Epiglottis is anyway not collapsing. His palate is still collapsing. So this is very, very typical. Now the AP as well as lateral collapse is majorly turned into AP collapse. Why? Because the mouth is now closed, so which is pulling his soft palate anteriorly. So the lateral collapse of the soft palate, the whole lateral wall has become straight, and therefore it's not collapsing. But the length of the soft palate is still quite a bit, even on the clinical examination. So you can see the palate is still collapsing, and it's majorly antero-posteriorly. Right? Can you see that? There is no collapse of the tongue base, so he does not require any tongue base epiglottic work. But he certainly needs his soft palate length to get reduced along with collapsibility. So, perfect candidate for suspension bridge pharyngoplasty. Perfect candidate. And long uvula. So either his length has to be reduced or uvula has to be rotated like a the uvulopalatopexy or a complete excision, which will take care of his snoring and sleep apnea both, along with correction of his nasal septum, septoplasty. You can see the height septal deviation once again. His septum is deviated on the left side on the higher part and spur on the right side, which is not very, very significant, but obviously when we correct, we correct also. Yeah. All right. So thank you for watching.